Where did I leave off? Bleeding, weakness, and fever. Chemotherapy is the most common treatment of ALL because it is a blood disorder, like it's a blood cancer, and since chemotherapy is administered through the blood, it can directly treat the cancer. And to the right, this is what your normal blood sample should look like, and this is what one filled with leukemia cells looks like. The one below it is a close-up, and the yellow arrows are pointing to the leukemia-infected cells. The next cancer is a brain or central nervous system tumor, and that makes up for 27% of all childhood cancers. Most of it start in the lower part of your brain, in the cerebellum or the brainstem, which is, these are like around this part of your brain if you didn't know. The symptoms are headaches, dizziness, and or balance problems, and that's because it's pushing and it's making a lot of pressure in your brain, and it's just going to throw off like the nerve transmissions and that kind of stuff. The best treatment is surgery because it will remove all of the cancer, the tumor itself, but sometimes it's not possible to remove it, especially if it's located like a brainstem glioma. You can't remove them. So the only thing you can do is to give chemotherapy and radiation pretty much for the rest of your life to reduce the size and prolong your life. And so that's kind of a pain to do that all the time. But some of them are just too big, and they can just take chemotherapy and radiation, and then it can be removed. So that works as well. The next one is neuroblastoma, and this begins with immature nerve cells in kids younger than 5 and in your adrenal glands. This makes up for 7% of all childhood cancers, and the symptoms are impaired ability to walk, eye changes like you get blurred vision, or pain in various locations, usually where the cancer is. And it's often is used watchful waiting for the treatment, which is if you have a low risk neuroblastoma, they will just keep bringing you back in for repeated visits and just make sure it hasn't gotten any worse. And if it does, then it will include surgery and chemotherapy to get rid of it. But most of the time it is found after it has spread through the blood and possibly to your organs. So that would make it a high risk neuroblastoma, and it would be like immediate surgery and chemotherapy. The next cancer I'm going to talk about is the Wilms tumor. And this is a tumor that starts in your kidneys, and it can be in both kidneys, but usually it's only in one. And it develops while the baby is developing, so while it's in the womb. And basically the tumor is a lump of immature cells that just haven't matured and they haven't grown. And this makes up for 5% of all the childhood cancers. And it's typically in very young children, 3 to 4, because by then the cells should have matured, and if they haven't, it's going to start causing problems. And symptoms are swelling lump in the belly, fever or pain. And surgery is always the treatment, and you can either have a radical nephrectomy or a partial nephrectomy, which a radical would be removing all of the tumor and your kidney, and a partial nephrectomy would be just to remove the parts that are infected. Chemotherapy and radiation follow surgery as a precaution to make sure that the tumor and the cancer don't come back. The last cancer I'm going to talk about is lymphoma, and it starts in the cells of the the cells of the immune system, and that would be either your T or B cells, and it affects your lymph nodes and the lymph tissue. It also affects your white blood cells because those are what make up your immune system and what fight your infections. And so this cancer really compromises your immune system before you even start getting treatment. Hodgkin's is a type of lymphoma, and it's rare in children under 5 and treated with chemotherapy and radiation. Non-Hodgkin's lymphoma is mainly in young children, but not younger than 3, and these cancer cells grow rapidly and they need immediate treatment, but they respond very well, so it's very high survival rate. I think it has like a 97% survival rate, so that's really well. And the symptoms are swollen lymph nodes, weight loss, fever, and sweats. Next I'm going to talk about late effects, and late effects are the effects that come after you're cured of cancer. So this is in between. This is like post 100 days, which means post 100 like days after you've been cured of or survived cancer. And they can consist of you could still be nauseous, you could be fatigued, depressed, have anxiety, you could have physical disabilities. Approximately 1 in 285 children will be diagnosed with cancer. The 5-year survival rate of childhood cancer ranges from 64% to 97%. And 60% or 2/3 will suffer from late effects. And out of those 2/3, 72% of them have fatigue. So that leads into my final product. So for my final product, I am going to do a study on cancer-related fatigue. And this is a very poorly studied side effect of cancer because it doesn't seem to be very debilitating, but it really is because it affects their quality of life and their hope. And that takes a really big mental toll on them, and they don't think they can get any better. They're really lazy and they don't want to do anything. And it's not the fatigue that you would experience if you didn't get a good night's sleep or you worked a long day. They're so tired and weak all over their body. They don't want to get up to use the restroom. They don't want to eat. They might even be too much for them to pick up the TV remote. So they're really not doing anything, and it's really decreasing their quality of life. And it really is something that does need to be looked into, because if it can be solved, they can have a better chance of going back to their normal life before they had cancer. So that is why I chose to do it. And Children's Health, which is where my mentor works, him and his group of colleagues did a pilot study about fatigue in kids with transplants, which is their like subspecialty of a subspecialty. And so that's also what put the bug in my mind and my mentor, Dr. Aquino's mind, to do this, because they didn't try to intervene with anything. They just wanted to take a survey to see how many of their own patients have fatigue. And it was more than 2/3 of their transplant patients had fatigue, and that's too many. So I decided that since this is something that hasn't been done, why not do it? So far, when I first started, I got really hyped up about it, and I thought it was going to be something that I could just easily do. But as I've learned, it's really hard, and it's something that I didn't ever, like some things I've never thought about in my entire life about this research, like how much plays into making a protocol, which is basically a book explaining to the IRB, which is the place that approves clinical trials. So it's basically explaining to them why your study is different than everyone else's study that's been done, why you think it's going to work, and then a step-by-step on how to do it. So you have to have, basically you have a primary question, which is the question you want to answer. It's your goal. This is what you want to find out with your results. Following that, you can have secondary questions that you're hoping to answer through your study that might just come out of it. And then you're going to turn your question into a hypothesis. So that's something that can be tested. After you have your hypothesis, you're going to start listing out your specific aims, the goals of the study, what you're trying to accomplish. And then after that, you start into your background. So for mine, I start doing a background on fatigue. I explain fatigue like I'm explaining it to someone who has no idea what it's about. So I just explain exactly how I explained it to y'all, that it's not like the normal fatigue, and it's hard for them to do regular activities like use the restroom. And then I will explain to them why I think it's different than other studies. So I had to go and look up studies that have already been done that are similar in ways to mine, but not the same. And then also studies of the drug that I'm going to use to intervene with the fatigue and try to decrease the fatigue, and explain why I believe that drug will work. And so that's really hard, and it's a lot of work because you just have to really know what you're doing and how to pull the articles and how to summarize them and how to put them in your background, and it makes for a lot of reading and writing, and more than I ever imagined. And then after that, I talk about who I want to be in my study. So that's something I didn't think about. I just thought, hey, everyone who's got cancer can just enroll into my study. Anyone who's got fatigue, come on in. But that's not how it is, because especially with the drugs that you use, you have to see what the drugs say, like who can't use this drug. And they can't be in your study because they can't use it. So like on mine, if you're taking a monoamine oxide inhibitor, which is just something that's put in other drugs, then they can't be on it because it has they don't mix well together, so they can't be in my study. And my study also has a survey that's only in English and Spanish. So if you speak Arabian, you can't be in my study because you can't read the surveys you have to fill out. Also, I want parents to fill out the survey of the children, because children can have a biased view on how they feel because they don't want to be taking this medication or something. So your parents have to be involved in your life. They have to see you and know if you're changing in your fatigue, if the fatigue's decreasing, or if you're having a toxicity or things are getting worse. They have to be able to notify that to me. If they're not involved in your life, then they can't be in the study because they won't be able to answer those questions that we ask them. And so those were things I never thought of until I really started getting into my study. After that, you have to have your study design, and I didn't really know that studies were designed in specific ways. So for mine, I don't want to be biased or have a placebo effect on my own study. So I want to be blind. I don't want to know who's on what medication, so that I don't favor one of the groups over the other. And my mentor as well would be blind during the study, because we don't want him to have a bias effect either, especially if he's collecting data on days I'm not there. So the only person that will know who's on what is the pharmacist, because they're administering the drugs to the parents to take home. That was also something I never thought about. I also thought you have to randomize your select group of kids. You can't just say like every other kid goes in different groups. There's actually like a program that mixes them all up and throws them into different groups. So I didn't know about that either. So that was something cool that I learned. And then after your study design, you have to explain the benefit of your study. Like, what's the point of it? What benefit is your patient going to see? And then you also have to explain the risk of your study. Can a patient die on your study? What levels of toxicity could possibly be seen in a patient? And the risk, you don't want, if your risks are too bad, they're not going to let your study be conducted, because they don't want people to be dying on your study. You also have to talk about, if you're using drugs, you have to put all the agent information, the side effects of your drugs, just so people know before they start doing it. They know what the side effects are going to be. You also have to make a consent form so that people they consent to do this. And I didn't really think about that. I was like, if they're already being treated, then they already kind of have done one, but you have to have one specific to your study, because if your study does get published and it's out there for everybody, then anybody can pull it off of a website that has like a database with a collection of these, and they can conduct it themselves. So you have to have all these things done like you were giving it to an amateur, and they would conduct it just how you did. So those are a bunch of things that I really never thought about, and there are cool things that I've learned about like just researching in general. Right when I started, my mentor, he gave me his first protocol, which he designed off of his mentor's protocol. So it's kind of like, passed down. So that was how I figured out how to design it, because there's a certain way you have to lay it out. Like, you can't just put can't start with your patient eligibility. You have to start with your question. There's a certain order and a way it has to be designed. And so that was interesting to figure out. And also, he kind of just let me kind of figure things out on my own. And he guided me, but he didn't do it for me. And I really liked that, because it was a way for me to learn about how I needed to work, and just like self-efficiency and doing my project on my own. And it feels really good in the end when it's accomplished, and it's like, my mentor didn't put this together, I put it together, and this is my work, this is my knowledge, I know everything that's in this protocol. And so that's really cool for me to see. So right now, this is all I have of my protocol. If you want to come look at it, I'm going to pass it around at final presentation. So that's my protocol, and you can read through it and see what I'm going to be doing with mine. It's basically everything I've said, but if you miss something, you can see how it's laid out in there. So the purpose of this study is basically to decrease fatigue in cancer patients who have undergone a bone marrow transplantation but are post 100 days from the transplant. Also, the purpose of this was for me to learn about research in the medical field and to see what it's like, because if I wanted to go into the medical field, this is something I'm going to have to do regularly, because my mentor still, sometimes something comes up to him and he has to research and figure out about it and learn more about it. And it was also to help me learn about writing protocols, because like I said already, if I go into this field, it's something that I'll have to do, especially if I want to conduct my own study. So since my study is not completely done and it's not like conducted, and I just kind of have the basis of my protocol done as of now, I am going to continue this journey with Dr. Victor Aquino throughout next year in ISM as well. And we are going to also work throughout the summer to try and get me research certified in the medical field and get my protocol peer reviewed by people there and by the IRB, so we can actually conduct the study and see if what we have come up with as a team, me and my mentor, will actually work and help decrease fatigue in cancer patients who have had a bone marrow transplant. So thank you for coming to my presentation, and I hope you enjoyed it, and I hope you learned a lot from it, just like I have learned from all these experiences I have had. Are there any questions? Okay, thank you. How long was that?